I'll invite Dr. Peacock to come to the podium.
So I'm an emergency doctor, and I'm going to give you my perspective. The first of this is point of care. And point of care is doing the tests next to the patient, as opposed to the central lab, which is usually 3 blocks away, and it's not convenient nor quick. And I hope by the end of this you understand why this is not just we do for fun because we can, that it's an integral, important part of the patient's life. And for an emergency doc, there's really 2 categories of outcomes. There's either you're dead or I don't care. If you're alive and well, you go home, that's great. But if you're dead, that's my problem. And so that's the way I think about things. And if you think about the list of things that you better treat quickly or they're going to be dead, this is where time is critical. And low blood sugar, you really have no way of knowing that without a lab test, is one of them. Hypoxia, which means no oxygen, same type of deal. These other ventricular tachycardia is a heart rhythm. You can actually tell that with a machine, so I don't need a point-of-care lab. But MI, heart attack, it requires either a machine or a blood test. Stroke, pneumonia, heart failure, all these require me to do something quickly or you may be dead at the end of the day. So the first thing I'm going to talk about is what's the impact of point-of-care testing. In other words, how much improvement do we get out of it? So this was, a friend of mine did this study, took blood samples from 4,500 patients at 5 different hospitals and ran them, split them in half. One went to the lab and one they did point-of-care in the ER right there. And what you can see here is these are all the different places. This is the hospital type. And this is the difference in minutes from the point of care to the central lab, POC versus CL. And you can see the difference averages out to about 65 minutes, an hour. And so the real question is, do you care about an hour? I mean, patients can just wait an hour, can't they? And we'll talk about that in a minute. This is a study I did. And this is a different type of study. This is patients who came into the ER, and we looked at the time the patient hit the door until the lab result was in my brain. Now, there's a lot more than just running a lab at that point. Patients don't come to the ER naked. They come in. They come in fully clothed. The blood doesn't jump out of their arm. It's got to be drawn, put in a tube, sent to the lab. You can't do it unless you're registered. Then that lab comes back on the computer, and it sits there on the printer for half an hour until I find it because I'm busy in a different room. So the door-to-brain time is everything it takes from the patient hits the door until I can do something with the number. And what we found out is the average central lab was an hour or 2 hours, and the point of care was 68 minutes. And people said, well, why does it take 68 minutes to get a lab test? Because the patient's sitting right there and you do the test only takes 15 minutes. And it's all those other issues that take time. You got to take the patient's clothes off and draw their blood, and they got to hold still, and sometimes you have to hold them down, and you get the blood out of them. And then you run the test, and then they got to find me with a number. So we still save an hour. So this is the data that says, is an hour important? This is a trial I did a few years ago on 42,000 patients. That's bigger than the town I went to college in. 42,000 patients, and we looked and found out that if you stayed in the ER more than 8 hours, you got bad care. In other words, patients did not get the recommendations, and these were all heart attack patients. So this is a high-risk thing. It's not stubbed toes. They could probably wait an hour, and I could care less. But a heart attack, I don't want to wait an hour. And these patients who stayed in the ER long times didn't get recommended care. What happens when you don't get recommended care for a heart attack? Your death rate goes up. Here's another one with 13,000 patients, and they found out that patients who were in really bad pain, like with a broken leg, who waited a long time, for every patient in the waiting room, the probability they didn't get pain medicine at all, none. You sat there with your broken leg and the doc said, suck eggs. They got there was a 3% chance of getting no pain medicine. So if there's 10 people in your waiting room, 3 of them got no pain medicines. This is 694 patients, and patients who had pneumonia, the more patients were in the waiting room, the less likely they were to get antibiotics. So you get the message here that hanging out in the ER for hours and hours with thousands of people in the waiting room is bad for the patients because they don't get pain medicines, they get bad heart attack care, they don't get antibiotics for their pneumonia. It's bad care. So long times equal bad care. The question is, and these patients were boarded patients, they stayed there overnight, and a third of them had something happen to them. So that's where it goes. Now, what does bad care add up to? It adds up to dying. What's the risk of dying? And here's where these numbers come out. For every hour you stay in the emergency department, your risk of death goes up by 10%. So why are patients hanging out in the ER? I don't want them there. The patient doesn't want to be there. It's because we have overcrowding within the hospital itself. And I can't move a patient up into a bed, they can't go. If they can't go to the ICU, or if it takes me a long time to diagnose them, for every hour they waited in the ER, in other words, before they saw the emergency doctor, that risk of death goes up by 20%. This is 62,000 patients in Australia. You can say, wow, that's Australia. You know, they're different than we are. This is 13.9 million patients from Canada. Their odds ratio for death if they stayed in the ER longer than 6 hours goes up by 80%. That's a lot. And this is Canada, a medical system not so different from ours. So here's those numbers. 14 million patients. Waiting equals bad outcomes or bad care. Does an hour matter? If you cross those magic thresholds, 6, 8 hours, something like that, the answer is absolutely. The death rate goes up. So this is why I'm really put a lot of emphasis on point of care, is because that chops an hour off that patient's length of stay. And my question becomes, what business would intentionally kill its customers? Well, there's that one. But otherwise, no business would want to. If you had a way of getting the data quickly, wouldn't you do it? I mean, why would you wait? So the era of point of care needing to justify itself is over. And what has happened historically is everybody says, well, it's more expensive and it's just a matter of convenience and there are no outcomes associated with it. And you really can't do anything with the numbers anyway, just in the end of waiting. And the answer is wrong. That patients who get their data quicker have better outcomes than patients who wait around a long time. So we're now in the era where the central lab, the lab down the hall, down 3 blocks down the road, has to prove they're not killing the patients instead of the point of care. So let me calibrate this. I have 3 jobs in the emergency department. I got to make a diagnosis, I got to do something to the patient, and I have to get them somewhere. You can't stay in the ER. You have to leave. Either go home, get admitted to the hospital, but that's the disposition pressure. So diagnosis, treatment, disposition are the 3 things an emergency doc has to do. And it would be really cool if patients came in and on their forehead was tattooed their disease. And so Bob Dole would say, but this old lady comes in and what do you know? What has she got? Well, I don't know. She's got COPD because she's a 100-year smoker, but you know, this is not how patients come in. They're not self-identified. You have to figure it out. And this is that diagnostic testing part. If you think the era of laying hands on the patient and some old doctor says, oh yeah, they have thyroid cancer. Well, that's just television. That is not reality. I can't do anything without a lab test. This is how shortness of breath, which is a very common presentation, chest pain, shortness of breath, abdominal pain are the big 3 in emergency medicine. So this is a common one, and it doesn't come in with a diagnosis. It comes like this. These are all the things that can cause shortness of breath, and I got to sort that out. So in the absence of a lab test, it's pretty tough. And if the lab test takes 4 hours, that's how long it's going to take me to figure it out. Well, is this important? Here is an ambulance study. This is 8,000 patients in ambulance, about 500 at heart failure. Heart failure is your lungs fill up with water, you get real short of breath, you call the ambulance. For me to call an ambulance at 4 o'clock in the morning, I'd have to be really, really sick. I'm not going to do that. So this is sick people, and half of them got treated and half of them didn't, so about 240 treated, 250 not treated. If you got treated for heart failure in the ambulance, you got treatment, you had to stay in the scene 2 minutes longer because it took 2 minutes to squish the drugs in through the IV. But you got it 36 minutes sooner than if you waited till you got to the hospital. So treatment now takes 2 extra minutes, but you get it a half an hour sooner than if you wait. Because if you wait, you got to get to the hospital, and then we got your clothes off and that whole routine again. And if they got treatment in the ambulance, you know what happens? The odds ratio of survival, the probability of living till the next day, goes up by 250%. That's a lot. So what the question then is, early treatment obviously works. Why don't we just give it to everybody? They all come in, we treat everybody short of breath like they have heart failure, and the mortality would go down, right? There's a stinger here. There are 106 patients who got heart failure treatment but didn't have it. And what happened to them? Their mortality was 13% compared to those people who got the right treatment was 3%. There's a 250% increase in the death rate for the wrong treated patients. So you have to be quick. That 36 minutes earlier treatment saves lives by 250%, but you cannot be wrong. If you're wrong, your mortality, you kill people. So why did the paramedics do this? I mean, they're not in business to hurt people. They want to do the right thing. And the reason this happens is because when you're in some guy's bathroom and he's on the floor and passed out and short of breath, it's really hard to get the right diagnosis. And they got no diagnostic tests. They're making it by laying hands on the patient and taking a shot. And that's what they got to do. I mean, we don't have answers short of point of care in the pre-hospital world for these patients. This is from one of the largest diagnostic studies ever done. It's 1,200 patients called the Breathing Not Properly trial. And what they did is looked at how often the emergency doctor was right when he just thought, this is the diagnosis. And the answer is clinical judgment was right 74% of the time. They were wrong 26% of the time. That's 1 out of 4. If you add a BNP level, which is a bedside point-of-care test, takes about 15 minutes, just a blood sample, the accuracy rate goes up to 81.5%. And people have told me, wow, that's not much of a difference, 74 to 81. I mean, what is that, 7.5%? Who cares? And my answer is, well, if you're one of those, it's 4 out of 5 or sorry, it's 1 out of 4 or 1 out of 5. What if you're the 5th patient? You want to be the 5th patient? Because I just showed you what happens when we get the diagnosis wrong, the death rate goes up. So the point is that this is the value of point of care in patients who come in short of breath and ultimately diagnosed with heart failure is that your misdiagnosis rate gets smaller. And that's what we all are working on in emergency medicine is how can I make that misdiagnosis rate as small as possible?